of the kidney is little deformed. You can see that this area of the kidney is little pushed, little different looking. So then you will say this is a mass of hypo or iso. When it is isoechoic, then it is a challenge. You will miss it again and again, because it looks same echogenicity of the cortex, and you may not see the border clearly. So then what you need to do, click the color. Then you will see the color is more in here, and you will see the feeding artery going around it. And you will see nowhere in the kidney there is an artery like that. Then you will understand, oh, this is a mass. Okay? And you have to recognize this mass in transverse view too. Okay? Then go in transverse view and see this mass. Okay? If you go in transverse view, you might see. So this is transverse view. Okay? You might see the mass is in the cortical. Okay, you might see. So when you see this, then measure the length, height times width. Measure for follow-up. Okay, you're going to measure the length and height, and you will measure the width. And you have to locate where is it located. It's in the middle or upper pole or lower pole. Is it in the sinus or is it in the cortex? Okay? You have to make a location. Locate the mass. And see, is there any distortion of the cortex or the sinus? Distortion. Then you have to look for renal vein and IVC. Look renal vein and IVC for metastasis. So then what would be the symptoms of this patient? What would be the complaint? Pain. What else? Painless hematuria. Painless hematuria means bleeding through the urine. And patient will complain, I don't have pain, but why my kidney color is like that? Sometimes patient will come with the pain. Then patient will go for ultrasound, then CT, then MRI. And why CT? Because the CT will delineate or look for further metastasis in the body. It is very important. So renal cell carcinoma is, so I told you, so 4th and 5th decade, middle age people, they have it. Okay, and it is not rare, it is common. Okay, and this is in the adult. But if there is another malignant tumor in the kidney, we call it Wilms tumor, right? That is for the newborn baby or 2 to 3, 4 years old people, baby, they have it. That is Wilms tumor, we discussed it before. But for adult, this is the cancer which is more common. So renal cell carcinoma, keep that in mind. There's a lot times you can miss it because of its echogenicity. It is in the cortical region, cortex is darker, and the tumor is also darker, high isoechoic. So now we'll discuss about the transitional cell carcinoma. Transitional cell carcinoma. Transitional cell carcinoma. Why its name is transitional cell carcinoma? So transitional cell carcinoma, it comes from bladder. Why? Because the bladder and ureter and renal pelvis have transitional epithelial cells. The inner cell of the bladder, if this is the bladder, and bladder has inner cells, so this is bladder, inner cell, this inner cells lining is a transitional cell epithelial, and this is the growth of the transitional cell epithelial. Transitional cell epithelial is cancer, tumor is always cancerous. So now this is transitional cell carcinoma. And we know that the ureter is coming, both side ureter is coming into the bladder, and ureter also has transitional cell carcinoma, transitional cells. So this transitional cell carcinoma can easily get metastasized into the ureter. Okay, and the ureter goes into the renal pelvis. So if this is the bladder, and this is the ureter, then you see if there is a transitional cell cancer is right here, transitional cell carcinoma is here, then you need to check the ureter, because the ureter will have the transitional cell carcinoma here, 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 and in the pelvis. So what would be the complaint? Patient will complain, I'm passing urine with the blood clot. And it's a long-term history, and patient doesn't feel good. There will be pain or pain-free, and frequency can increase. Then you have to understand nobody will tolerate that my urine is blood clot. And I'm passing the blood clot. So now, patient may feel like, or maybe it's coming from the kidney, hematuria. So now, they will look for the bladder, ureter, this is bladder, and the kidney, that is the renal pelvis, and they will look for the kidney. So usually this type of situation, they will do the initial examination of the bladder by ultrasound. Then you will see what? You will see hyperechoic. So this mass is echogenic. Echogenic mass. Echogenic mass protruding towards the inside of the bladder. And it is usually not only one places, more than one places. Hyperechoic mass and wall thickening. You will see the wall thickening. Normal wall thickening of the bladder is in distended condition. It should not be greater than 3 millimeter. But here you will see it is more thicker, irregular structures and echogenic. And then go to ureter, you may not get it. Then go to the renal pelvis. You see renal pelvis has also some mass in the renal pelvis. Okay, so that's the way you can figure it out that this is transitional cell carcinoma, it may be. So then they will do the biopsy and they will do the further evaluation and they will diagnose finally. And if it is a cancer, so they will figure it out. They should do the surgery or radiation, chemotherapy or combination. Okay, so this is the solid tumor. So now after the solid tumor, then medical renal disease. Okay, now I can erase this part. Medical renal disease. The ultrasound is used to evaluate the kidney for medical renal disease. Medical renal disease causes renal failure. And this renal failure are two types. Two types, acute and chronic. Acute renal failure and the chronic renal failure. Acute renal failure is better prognosis than the chronic renal failure. Acute renal failure is reversible and chronic renal failure is non-reversible. And it needs renal transplantation. It needs renal transplantation. Now, acute renal failure. Let's talk about the acute renal failure. Acute renal failure is a sudden due to, example, dehydration. due to dehydration and okay, due to dehydration, toxin like a venom, snake venom, and also the gangrene. People has a gas gangrene or intestinal gangrene. It produces a lot of toxic materials and it causes renal failure. So now, if there's a renal failure due to dehydration or due to toxin, so then doctor will try to make it hydration. Simple diarrhea, loose motion can cause dehydration. You know that, right? And that can cause renal failure and patient may die within 24 hours. But it is reversible if you do the hydration by IV fluid. If there is a toxin, is a venom, so there is a anti-venom medicine they can counter. And then sonographically, sono appearance in acute renal failure, you might see normal sono appearance, or hyperechoic. Why? Because it is dehydrated. When you compare with other patient, then you will see it is little hyperechoic. The size will not change. Then look for arterial flow. As it is dehydrated, so resistance will go up. Look for the renal artery. Resistivity index is greater than 0.7. Okay, so in this way we can evaluate the acute renal condition, but sonographic necessity is not very important for acute renal failure. In acute renal failure, they will look for BUN and creatinine. Okay, so and they will look for what was the causes. So BUN will go up, creatinine will go up, but it is reversible. But in chronic renal failure, that is our field of discussion. In chronic renal failure, what do you mean by chronic renal failure? Means it's long-standing diseases, chronically causing the damages of the renal nephron. Chronic renal failure. Chronic renal failure diseases. The two medical renal disease that can cause renal failure chronically, one is hypertension and another is diabetes. So if it is, both of them are uncontrolled. If both of them are uncontrolled, when somebody has uncontrolled diabetes, uncontrolled high blood pressure, it will gradually, slowly will damage the nephron, uncontrolled. So then it damages the nephron. And we know the nephron is the functional unit of the kidney. And each kidney has 1 million nephron. No, 1 million nephron. And if the nephrons quantity is going down because of the death, so then what's going to happen? The kidney function will be deteriorated. So then patient will have more hypertension. Patient will develop more blood pressure. It is not controlled. So now the damage of the nephron means killing of the kidney. Killing of kidney which is irreversible. Irreversible. Irreversible means patient needs renal transplantation. And this disease causes bilateral renal failure. Bilateral renal failure. That means both kidney will be failure. So now, what would be the sono appearance? How I'm going to know this patient having the chronic renal failure disease? Because you have to take the history. You have to take the history. Then history will tell you that patient has long time uncontrolled high blood pressure and the diabetes. And you know the high blood pressure, diabetes are present all over the world. All over the world. Take the history, then physical examination. Okay, you will see the patient is anemic. Patient is swollen because the patient's whole body is filled with edema. Okay, physical examination, you will see the renal failure signs and blood work. Check the blood work. Then you will see the blood urea nitrogen, then creatinine are abnormal, then electrolytes are abnormal. So then you will know that okay, patient has already damaged in the kidney. So now after that, what you're going to do? You're going to start the ultrasonography. So then what will be the sono appearance? So you will see the kidney is smaller. Kidney sizes are smaller on both sides. Then kidney echogenicity is hyperechoic. Hyperechoic means the echogenicity greater than liver. Echogenicity is greater than the liver. Liver is medium level hypoechoic, but you see the kidney is hyperechoic than the liver. Renal cortex is hypoechoic, more darker than the liver. But now you see liver cortex is brighter than the liver, and on both sides. So then do the renal artery flow. Check it out. Then you will see decreased flow. Decreased flow. Why decreased flow? Because the decreased amount of nephron is taking the decreased amount of blood. That's why flow is decreased. Okay, and you will see the resistivity index is high. Resistivity index is high. So then you can, with the history, physical findings, blood work, and your sono image, they will tell, oh, okay, patient has chronic renal failure. Okay, so we got it. So what is the next thing is renal transplantation. Okay, so renal transplantation is important for the sonographers because sometimes you will get the transplanted kidney for examination. What is transplantation means? Transplantation means the replacement. This replacement of the kidney takes place in two ways. When there is an acute renal failure, and due to, I mentioned, dehydration and some other toxin, something, and they said patient could be saved if immediately we can change the kidney, but which is not possible because within a short time you cannot get the kidney.
Okay. You mean for chronic renal failure? Why acute?
No, it is acute renal failure, but if the kidney is ready and that it is not reversible, patient will be diagnosed, patient will be evaluated that the kidney is dead now. So then patient will be on dialysis, right? So then they will get the replacement of the kidney, get an idea. So this is one situation. Okay, let me give you another. It's a three. When there is a bilateral polycystic disease. And gradually kidney function is deteriorated. So then they will replace the one kidney. And chronic renal failure. Chronic renal failure. Okay, so now this is the most important things. Okay, when they found that patient has a chronic renal failure and patient's lab work are deteriorating, right? At certain point, then doctor will say, okay, we can start the dialysis now. Dialysis. So then, at the same time, those who have a chronic renal failure, the doctor, according to the deterioration, doctor will ask, okay, go to that hospital and enlist your name or register your name that you are a renal plant recipient. Okay, so now, dialysis. Dialysis can be 1 year, 2 year, 3 year, 4 year, until the match is done. Until a donor is found. Okay, so now after